Good morning. It's my pleasure to share in this valuable meeting the first annual international conference of Clinical Pharmacology Department, Mansoura Faculty of Medicine. I would like to thank and appreciate the kind invitation of Professor Ahdi. Today, I'm going to speak about a very hot issue, which is precision medicine in nephrology, or toward the personalization or individualization of our management strategy. To start, there are many advances and explosion in technologies, from molecular up to genetic, the engineering. So the personalized medicine harnesses a subject's own data to individualize their own care from diagnosis through treatment, selection, and monitoring. And as you see, there are many areas of innovations, from genome guided medicine. Nowadays, we have genomics, and the science of omics is expanding. So we have genomics, transcriptomics, proteomics, metabolomics. We have pharmacogenomics. So a lot of omics are there. And we have explosion from the technical point of data and data processing from the computerized science. So we have computer nephrology. So we have a lot of innovations seeking toward improvement of the patients, to protect and to treat our patients. Let us go to the clinical part of the presentation. And I'm going to start with choices of antihypertensive drugs in chronic kidney disease. This is what we agree upon. That if the patient has proteinuria and he has CKD, the best choice is the use of antihypertensive drug with maximum antiproteinuric effects, like angiotensin converting enzyme inhibitors or angiotensin receptor blocker. And then, if the patient is edematous, diuretic is the second choice. And if there is no edema, we may use calcium channel blockers. And added the third, and lastly, mineralocorticoid receptor antagonists to be added. This is the order, prescribing orders in chronic kidney disease. We are still in the nephrology patients, but now we are dealing with hypertension and dialysis. So beta blocker, which is not present as the one of the first in treatment, and it is dedicated only if there is congestive heart failure for ischemic heart disease. In dialysis, it is on the top. Why? Because in dialysis, there is increased sympathetic overactivity. Let us go to this very recent article addresses the use of antihypertension in dialysis patients. So this is a meta-analysis for 40 trials included in this meta-analysis, trying to answer, is there is any efficiency of any class? So they compared to placebo, angiotensin converting enzyme inhibitors, beta blockers, calcium channel blockers, aldosterone antagonists, assessing their capacity to reduce systolic blood pressure in dialysis patients. And the key message which worked best from this meta-analysis, it seemed that aldosterone antagonist is the number one, followed by beta blocker. So beta blocker has its own advantages, again, in dialysis patients. And if you look at ACE inhibitors, ARB, calcium channel blocker, they are on the third order. Here for beta blocker, I would like to address important points. If the patient has intradialytic hypotension, so the carvedilol, which is not dialyzable or minimally dialyzed, I think it is not the good choice because it will increase intradialytic hypotension. But if the patient has intradialytic hypertension, carvedilol will be the best because it is not dialyzed. So this is the choice. I would like to add a point here. When we prescribe beta blocker, this is my opinion, is to look at the pulse, because bradycardia is bad and may be associated with mortality. So we should individualize our treatment and follow up our plan. And from the safety-wise, ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists have many side effects in the dialysis patients, increasing risk of drug discontinuation due to adverse effects and hypotension. As you know, aldosterone antagonists, the main side effect is hyperkalemia. And for the first generation, we may find gynecomastia and others. Regarding diabetes management in chronic kidney disease. In the current issue of Kidney International, you'll find the executive summary of the 2020 KDIGO guidelines for diabetes management in chronic kidney disease. I'm not going to discuss all the details, but look at this point. If we have the patient in the early stages of CKD, while GFR is still within normal range, here our goal for glycemic control is to intensify glycemic control to retard the progression of chronic kidney disease. But if the patient has advanced stage of chronic kidney disease, stage 5, then our target of glycemia control becomes more toward more relaxation. So A1C may be around 8% or less. Why? Because we are afraid of hypoglycemia. So according to the CKD staging, our target changes from intensive glycemic control to protect the kidney toward avoiding hypoglycemia to save the life of the patients. And you can see here different demographics for different patients dictate where we go, either toward intensifying glycemic control or toward relaxed glycemic control. So if the patient has short life expectancy or multiple comorbidities, then we should be relaxed in our treatment. After lifestyle modification and the metformin, we have two big categories and the classes of drugs: sodium glucose cotransporter 2 inhibitors and glucagon-like peptide 1 receptor agonist. If we have diabetic kidney disease, we should answer two questions: what is the level of albuminuria, and what is the level of estimated glomerular filtration rate, eGFR? If we have high grade of albumin creatinine ratio exceeding or equal 300 milligram per gram and estimated GFR above 30, sodium glucose cotransporter 2 inhibitor will be the best to be added for the treatment of diabetic patient. This is why, because we have these two trials. One study was published last year, canagliflozin and renal outcomes. So here, the primary outcome was renal, and the canagliflozin was associated with beneficial renal outcome in diabetic kidney disease patients. And the most recent, still online, the article of dapagliflozin in patients with chronic kidney disease. DAPA is beneficial for the kidney. So these are two trials. The primary endpoint was renal outcome. And the most important point in the DAPA kidney study is 2/3 of patients were diabetic and 1/3 were non-diabetic. So it seems that dapagliflozin has beneficial effects for diabetic and non-diabetic. So very exciting. So here, if estimated GFR is above 30, because here the inclusion criteria was GFR above 25. So above 30, we have high albumin creatinine ratio, sodium glucose cotransporter will be the best to be added after lifestyle modification and metformin. Here, if estimated GFR is less than 30, here we cannot prescribe sodium glucose cotransporter 2 inhibitor until we have new evidence for that. So glucagon-like peptide 1 receptor agonist is the best. Even metformin is restricted if estimated GFR is less than 30 milliliter per minute. If albumin creatinine ratio is not high, then we assess heart failure risk. If the patient is in the high risk category of heart failure, again, sodium glucose cotransporter 2 inhibitor is the best. This just an example of the issue of personalization and using algorithm toward the individualization of treatment. And more importantly, so long as we are living in the COVID era, if the patient is diabetic and has corona or SARS-CoV-2 virus infection, does COVID-19 have any impact on the choices of anti-diabetic drugs? Yes. Look here, I just say that sodium glucose cotransporter 2 inhibitors is very interesting for kidney and heart for cardiorenal benefits. Look here for COVID, because there is increased risk of dehydration and euglycemic ketoacidosis if we use sodium glucose cotransporter 2 inhibitors. So suggestive for practice, stop them if oral intake is not tolerated, because this will increase the risk of euglycemic ketoacidosis, or the patient has severe illness. In this situation, sodium glucose cotransporter 2 inhibitors is not advised at all. The same for glucagon-like type 1 receptor agonists, gastrointestinal side effects, so stop them in all patients, severely ill patients. DPP4 inhibitor may be advantageous for the majority of patients because it blocks DPP4, which is the portal for the virus. And so long as this class is associated with low risk of hypoglycemia, so it may be continued, but in non-critical ill patients. So in all critically ill COVID patients, the treatment is insulin, not oral hypoglycemic drugs. So what is the direction now and for the future? It is time for clinical decision support systems tailoring individual patient therapy to improve renal and cardiovascular outcome in diabetes and nephropathy. Critical care nephrology and personalized medicine. I'm not going to bother you by details, but these are the different type of shock. I would like to highlight and comment on only two types. Cardiogenic shock. In cardiogenic shock, you will find the high systemic vascular resistance and the low cardiac output. While in septic shock, there is reduced significant reduction of systemic vascular resistance and increase the cardiac output. So if we decide to support the hemodynamics of these patients, how to select which agent is the best for cardiogenic shock? Again, we have increased the vascular resistance, so we need vasodilator, and there is low cardiac output, we need inotropic. This is why in cardiogenic shock, drug with inotropic effect and vasodilating property, which is dobutamine, is the best to start with. While in septic shock, vascular resistance is significantly reduced and the cardiac output is high. So we need the agent which has potent vasoconstrictor effect to increase systemic vascular resistance. So norepinephrine, and in resistant cases, phenylephrine are the best choices for our patients. So this is how personalized medicine help us in management of our patients. Regarding CRRT, precision renal replacement therapy for patients treated with support replacement therapy, continuous renal replacement therapy. We have laboratory data, we have demographics and the clinical data of the patient, and we have advances in machine. All the data coming from all these portals are analyzed by high-tech computerized programs. And these programs have their feedback even automated to the machine to change the prescription of CRRT and to give feedback for nurse and physician. It seems this is the future treatment is toward personalization and automatization. Dialysis strategy. I like this supplement because this is the supplement of NDT about advances in chronic kidney disease and dialysis care, a joint call for personalized therapy. It is very important to be addressed. One of the important articles within this supplement is the landscape 2030 of renal replacement therapy. We are expecting a major change from population toward precise and individualized treatment. And this is the panoramic view of blood purification. As you see here, this is the tailoring treatment. So we need enhancing global treatment efficiency, yes, for all, dialysis dose and tolerance, high volume hemodiafiltration, flexible treatment time according to the patient demographics, monitoring dialysis performance, and the individualized dose scaling. So this is individualization according to the patient characteristics and the patient's demographics. Preventing dialysis-induced stress, precise handling of sodium according to the patients, reducing blood dialysate interactions, and tailoring individual electrolyte prescriptions in dialysate, and for the patient according to the patient values, serum values of potassium, sodium, potassium, bicarb, calcium, and magnesium, and others. So it is the toward uh, improving the efficiency and tailoring toward individualization. The proof for individualization, if we have patient with heart failure, the patients with heart failure cannot tolerate a long dialysis session. This is why for patients with heart failure, it may be more suitable to go to more frequent dialysis rather than prolonged dialysis. The same for pregnancy. We need intensified dialysis in pregnancy for the sake of baby. This is why we do daily dialysis or at least 5-day dialysis per week. This means that we change our prescription according to the patient demographics. Even screening for cancer, because there is increased risk of cancer in dialysis patient. Unfortunately, hemodialysis or dialysis affects the validity and the performance of screening test for malignancy. So fecal occult blood in a stool is affected by tendency of subclinical mucosal bleeding. Mammography for cancer breast is affected by the presence of microcalcification in the milieu of renal failure and dialysis, and the false positive tumor markers. And here, the free to total PSA are not as useful in general population. So screening tests may be not specific and they may be affected by the environment of dialysis. So false positive results are high. And all these points to put in mind when we decide for our patients. Renal transplantation. Tacrolimus is one of the most important drugs, maintenance immune suppressive regimen, and it is the backbone of immune suppression of our patients. One of the very important clinical issue is inter-patient variability. What's meant by inter-patient variability? If we use fixed dose for different patients, we can find different levels and different effects. This is why we should be interested in this issue toward individualization. And to convince you, and this is one of the old figures showing the ABCB, it is a multi-drug resistant gene which is responsible about drug absorption and the efflux system. If this is the intestinal cell, and this is the genetic makeup of this individual for ABCB gene polymorphism, as you see here, if the genetic makeup of the patient is following CC, this means that the pump is active, that efflux is a drug toward the lumen. So absorption is reduced. So this is the fraction of the drug absorbed. If the genetic makeup is CT, the absorption is midway because the pump is midway, is not like this man. And if we are here, the genotype is TT, pump is lazy. This means the majority of drug is absorbed. Suppose that we used fixed dose of tacrolimus, 0.1 milligram per kg, then what's your expectation for the level of the drug? If we give the same dose for these 3 persons, everyone will have different drug level. This is what's meant by individualizing our treatment. So if we know in advance, preemptive, the genetic constituents of the individual, we can think to modify the dose to face the genetic and absorption capacity. This is one of our articles that is published in August this year in the Frontiers in Pharmacology about cytochrome B3A5. Here I'm not speaking about absorption, I'm speaking about the metabolism. So we have different metabolismic capacity in different persons. So what about cytochrome B3A5 gene guided tacrolimus treatment of living donor Egyptian kidney transplant patients? This is the study. We determined the allele frequency of cytochrome B3A5 to address if the patient is within the slow metabolizer or in the fast metabolizer or heterozygous, heterogeneous. So this is the 76 renal transplant patients of Egyptian descent, and we evaluated the influence of cytochrome B3A5 gene variant on tacrolimus dose required for these patients. And this is the method, PCR restriction fragment length polymorphism. And this is the main results. If you look here, the majority of our patients, 72% of our patients are belonging to slow metabolizers. It is cytochrome B3A, star 3 dash, star 3. This is the slow metabolizers. And this heterozygous, the star 1, star 3, this means that it is heterogeneous or heterozygous regarding the capacity to metabolize tacrolimus. Homozygous fast expressor, only 1.3%. So the majority of our patients were in slow metabolizer group. What is the impact of lowering cytochrome B3A5 capacity of our patients? This is concentration per dose ratio. The lower the concentration to dose ratio, the slower the metabolism. So this is why here you can find concentration dose at the first time and at 1 year for slow metabolizer group in this range. You can in this just a look here, you'll find the concentration dose is low in the first time and after a year for those who are expressor or fast metabolizers. So this means that the capacity to metabolism for the metabolism of tacrolimus affect dosing of tacrolimus in our patients. Another point, this is from the basic, how tacrolimus work. Tacrolimus enter the cell in cytoplasm, binds to immunophilin to form a tacrolimus immunophilin binding, and then to inhibit calcineurin. By inhibiting calcineurin, this will inhibit nuclear factor of activated T lymphocytes and with subsequent reduction of cytokine. This is why we changed our mind. Nowadays, we monitor tacrolimus by monitoring tacrolimus blood level. This means that we are monitoring pharmacokinetic to assess bioavailability. So how, if we change from bioavailability toward the pharmacodynamic, toward the response? This is why we have this MD thesis of nephrology for nuclear factor activated T cell regulated cytokine gene expression for tacrolimus pharmacodynamic, because the first response from action of tacrolimus is reduction of NFAT. So if we measure NFAT expression and to have it in a certain range and correlate the value of nuclear factor of activated T lymphocyte related gene expression to the clinical parameters, we have patients who are admitted to the hospital with pneumonia, and we have patients who are admitted because of rejection. The question is, if we evaluate nuclear factor of activated T lymphocyte related gene expression in pneumonic in the group with pneumonia, and then we find nuclear factor activated lymphocyte was significantly reduced, this means that the patient is in over immune suppressive state. And in the rejection group, we find it is high. This means it is not reduced. So we are far below the immune suppressive state. This will refine our management to combine pharmacodynamic with pharmacokinetic, because at the end of the day, we need pharmacodynamic, we need effect, and we don't like side effects. So if we review ourselves, then we can leave the patient with a little bit low level from pharmacokinetics, so long as the efficiency of reduction of nuclear factor of activated lymphocyte related gene expression is within the window. So this is, we are waiting this pilot study to answer this question. Another interesting point is to use the viral load, torquetinovirus, PCR. It is it is the virus that can be tested in the blood, but without any clinical manifestation. It reflects the state of immune suppression, and we need it in a certain range. So between million copy per milliliter to 100 million copy per milliliter, this is a state of well adequate immune suppression. If we have the virus level is very high, this means that the patient is over suppressed. If it is reduced, this means that the immune suppression is not enough for our patients. So this is, I think it is exciting issue. Another area of personalization, if we have a lady transplanted and delivered and now thinking of lactation, what is the effect of immune suppression and what are our advices for the lady? Suppose that we are speaking about prednisone and steroids. So safety in breastfeeding is acceptable. So we continue breastfeeding while the lady is on prednisone or steroids. Cyclosporin, acceptable for use weighing risk versus benefit, present in breast milk, variable concentration. So we allow the lady to lactate while she is on cyclosporin or tacrolimus. So the safety is accepted. But for mycophenolate mofetil, no. So this is why if the lady decided to lactate, mycophenolate mofetil shouldn't be used. During whole pregnancy, we stop mycophenolate and replaced it by azathioprine. In lactation, if the lady decide to lactate, then we continue stopping mycophenolate mofetil. Azathioprine can be used during pregnancy because even if it is transferred by placenta, the fetal liver cannot transfer azathioprine to the active constituents, which is 6-mercaptopurine, so the baby is protected. So the inconclusive data for safety in lactation can be used at lower doses. So, and the manufacturer doses doesn't recommend use of azathioprine. As a general rule, what we do, in the past, we don't advocate lactation, but nowadays we changed our mind based on the literature. So we can allow lactation if the lady is maintained on steroid, calcium inhibitor, either tacrolimus or cyclosporin, and azathioprine. But we don't allow lactation if the lady is on mycophenolate mofetil, mycophenolate sodium, sirolimus, or everolimus. So this is the general rule. So this means that we personalize our medicine even in this issue of lactation. For COVID patients and transplantation, this is one of the very recent, it's just accepted article about the use of biomarkers of cytokine release syndrome to predict the outcome and severity of the disease of COVID in transplant population. This is a small sample study, but give very exciting. If we know C-reactive protein, interleukin 6, high sensitivity troponin I D-dimer, and this is a cutoff point, above 100 C-reactive protein, above 65 interleukin 6, above 30 nanogram per liter high sensitivity troponin I, above 960 nanogram per milliliter D-dimer. This, if we exceed the cutoff point, this predicts severity of the disease in hospital and as well mortality. So it seems that we are moving toward the personalized medicine and from just treat the patient with a dogma to individualize the treatment to every patient according to his demographics and his data. I think this is the last point to declare. I would like just to pay your attention to our ASNT Virtual Academy that includes this huge number of lectures and videos, and this video will be uploaded to the YouTube. I hope that you are convinced by the issue of personalized medicine and the precision medicine in nephrology. And if you have any comments or questions, please write it in the YouTube video. Thank you and goodbye.